For this lesson, we're going to be talking about mobility. We're going to be talking about mobility for our clients and what immobility might mean for them. We're also going to talk about mobility as the nurse or caregiver and ways to help prevent injury to ourselves as well. So objectives, we're going to go over the musculoskeletal and neurological systems and how they regulate movement, talk about proper body mechanics, discuss the effects that lack of movement has on bones, muscles, and joints, assess the client's mobility status, and demonstrate proper techniques that support client mobility and prevent complications of immobility. So what is mobility? It's motion or movement. Our muscles, skeleton, and nerves all work together to have movement. We need it to perform daily tasks. And then immobility is just the inability to reposition or move oneself. Our bodies are designed for movement. They require these systems, our musculoskeletal and our neurological systems, to work together in order to perform those movements. We need it to perform daily tasks such as bathing, brushing teeth, driving, cooking. So we're really limited if we don't have our mobility. So the musculoskeletal system, it is a general term referring to the muscles and skeleton. It's a detailed grouping of tissues. These tissues include muscles, bones, joints, tendons, cartilage, and ligaments. And it is all important for stability and proper body functioning. So our muscles are soft tissues that provide motor power and force for movement. And bones are that hard connective tissue that create the rigid structure and shape of the human body or the skeleton. Tendons connect muscles to bone, and ligaments connect bone to bone. Synovial joints enable movement and flexibility between bones. Okay, and so here's just a little picture to kind of help you remember tendons versus ligaments. This is always hard for me to remember. But so for the tendons, you can remember like a tender muscle is attached to bone, and then ligaments is bone to bone, and you can think of like a long bone in the body. So long bone, ligaments, bone to bone, tender muscle, muscle to bone is the tendon. So skeletal muscles, their main function is movement. They work with the skeleton, and they help to maintain posture and body positioning. Without our muscles being strengthened, we would maybe be falling over or couldn't hold ourselves up. Like think of, a newborn baby. They don't have those muscles built up yet. They can't really hold their head up or sit up or anything until they get a little bit older and those muscles are strengthened. They also generate body heat. So our skeletal system, so it's our solid, stable framework. It protects our internal organs, our ribs, protect our heart, lungs, everything in that chest cavity. It produces red bone marrow, which in turn, that produces red blood cells, white blood cells, platelets, and macrophages. It stores calcium, phosphorus, magnesium, iron, and lipids. And then bones also play a huge part in movement because they're attached to the muscles to create motion. So the neurological system. So we have our central nervous system and our peripheral nervous system. There would be no movement without this, and if our neurological system can't communicate with our musculoskeletal system, like you might see with someone who is paralyzed, then there's not going to be movement. So the central nervous system consists of the brain and the spinal cord. The peripheral nervous system is made up of thousands of nerves that interface with the spinal cord. So they branch off of that and go to the periphery of the body. These nerves communicate with muscles and sensory receptors through neurotransmitters, and this enables the body to coordinate, balance, fine-tune body position, and movement. So the key principles of this are body alignment, balance, and body movement. Proper body mechanics lowers the risk for injury by lowering stress and strain on the body. So there's a vertical line, an imaginary vertical line that should run from the top of the head straight down through the earlobe, shoulder, trunk, hip, femur, knee, and ankle. So that's proper body alignment when a person is standing straight up. It's important to try and maintain this alignment when you're handling clients or lifting objects, and that you keep your back straight and then your the chin level, and to tighten your abdominal muscles to maintain the alignment throughout the task, and to also use your leg muscles. Your quadriceps are your strongest muscles, so utilize those rather than muscles in your back or shoulder, something like that that's gonna be injured easily. Okay, this already. The imaginary line, as you can see, this nurse or caregiver here, she's using good body alignment. She's got her back straight and she's bending her knees, and she's using a gait belt, which we'll talk about here in a little bit. Okay. And so here's just a picture kind of illustrating what that line looks like, and so you can see that they're in proper alignment. So balance, it's an even distribution of weight, enabling someone or something to remain upright and steady. We all have a center of gravity, that's a central point of weight for any object or body. The line of gravity shifts as the person changes positions. So as you can see, one standing, their center of gravity is in one place, and then whenever they start walking, they lean forward a little bit, so our center of gravity moves forward. So you can see the one all the way to the right here is someone that's walking with a walker, but they're leaning over too far, and their center of gravity is not where it should be, so they're more likely to lose their balance and fall. So for proper body mechanics, you want to stand or move as close to the object as possible. So whenever you are maybe turning a patient or doing a bed bath, this is why it's really important to raise the bed to a good working height, which is usually about to your belly button, so you're not having to really bend over. And then anytime you're lifting, you want to have them as close to you as possible, because you're more likely to hurt yourself. It's also a lot harder to lift when you don't kind of have that, when you're not pulling the object or moving the object close to you. And so we talked about keeping the abdominal muscles contracted, and then the lower back should be in a normal position. Shoulders, maintain the head upright with shoulders raised up. Bow the hips slightly and squat. Do not twist the torso. Always pivot. So if you're going to turn a certain way, always pivot your feet to point towards that direction. Never twist your torso. And then you're going to push up with the knees and use the momentum to lift the object. So now we're going to talk about effects of decreased immobility. And this may not seem like something that would be a big deal, but you're going to see today that it can cause a lot of problems. And so as a future nurse, you need to be proactive in promoting good mobility for your patients. So our bones, muscles, joints, they all require motion to stay healthy. So bed rest for even as little as 1 week can affect the client's ability to move. When they're immobile, this contributes to loss of mass, density, and strength in the bones. It leads to muscle atrophy. You guys have probably heard of this before, but when the muscles become weaker and smaller, It also results in poor coordination and ability to perform ADLs or activities of daily living, kind of like we talked about earlier, just kind of your basic stuff like hygiene, cooking, driving, day-to-day activities. Joint contractures are an abnormal fixation of a joint due to changes in muscles and connective tissue. Unfortunately, you will see patients like this where their arm or leg, wrist, a joint is fixed in a certain position and it's stiff, and they can't move it out of that position because they've been immobile for too long and weren't able to practice the right range of motion exercises in order to keep those joints loose, and then they are pretty much stuck there. So for foot drop, this is something you will probably see as well. It's really important with foot drop. This is when it results in a partial or total inability to pull the toes up towards the head. So they can't use dorsiflexion. They are pointing, their feet just look like they're pointed. And this is from maybe the bed linens being too tight and kind of pulling down on their feet, and they don't move them, and then they get stuck like that, and then they can't pull them back up. So this is really important when you're making a patient's bed to make sure the bottom is loose. You want to just make sure it's loose over their feet so it's not putting them at risk to develop foot drop. Okay, so now we're going to talk about how decreased mobility affects the cardiovascular system. So cardiac deconditioning is atrophy of the heart muscles. So we talked about atrophy of like skeletal muscles, but your heart can also, that is a muscle, and so it can atrophy. And so then it's going to be less effective, and there's going to be a decreased amount of blood being ejected from the heart. Orthostatic hypotension is a decrease in blood pressure that leads to dizziness when a client sits or stands. You will probably see this too sometimes, so you definitely want to make sure that you know this about your patient, or if you think they may be at risk for developing it. Anytime you get them up, you want to make sure they sit on the side of the bed for a little bit and kind of so they can kind of equal out, and when they stand up, they're not going to pass out. We actually, in the hospital not that long ago, there was a patient who had severe orthostatic hypotension, and he had got up by himself to go to the bathroom, and he ended up passed out in the bathroom floor with no pulse. So he got a couple rounds of CPR. He was okay after that, but extremely sore, obviously. But this can be something very serious, so it's important to watch for this. Also, deep vein thrombosis. So a thrombus is a clot. It develops in one or more of the deep veins, arms, pelvis, thighs, lower legs. You'll see in the hospital that a patient usually has some kind of VTE or DVT prophylaxis. It is either with TED hose, SCDs, or pharmacologic. So a pulmonary embolism is a serious complication of a DVT, and this is when a thrombus breaks off and can travel into the lungs. And then the same thing, if one travels to the brain, it can cause a stroke or a CVA. And then when the thrombus travels to the heart, it's a myocardial infarction or a heart attack. So you can see this is some really scary stuff that can just happen from someone being immobile for too long. Okay, so our respiratory system. Atelectasis, this is a word that you will see a lot on when you're looking at x-rays. You'll see this word a lot, and so it means partial or complete collapse of the lung. It includes airways and small sections of the lung tissue. So, So immobility, especially when the patient is the supine position, that means they're on their back, reduces the amount of air exchange and increases the risk for infection. It impairs the ability of the rib cage to move freely and to expand. So there's kind of a restriction there in that position. It can also cause the abdominal organs to shift toward the diaphragm, so further decreasing the depth of breaths and the effectiveness of coughing. Prolonged bed rest can result in structural changes in the lungs, evidenced by narrow airways, particularly the bronchioles. Clients who are immobile are frequently experience dehydration, and this causes the mucus to be thickened. The mucus in the secretions in the lungs are thickened, and it makes it difficult for the client to get rid of that mucus. And so that puts them at high risk for pneumonia as well. And so pneumonia is the infection that occurs in clients with limited mobility as a result of shallow breathing. And then they have the thickened mucus from being dehydrated, and then they have the muscle atrophy of their diaphragm and a decreased ability to cough. So all these things together put them at high risk for lung problems, specifically pneumonia. Okay, so our gastrointestinal system. So malnutrition, as activity slows, the absorption of protein from the GI tract decreases. Constipation is very, very common in those who are immobile or bedridden for even just a few days at a time. It occurs 16 times more in patients who are prescribed bed rest versus those who are active. Also, opioid medication will slow the motility as well. So a lot of times when patients are in the hospital, they're getting something maybe for pain, maybe some morphine, and this is going to also contribute to the constipation. And then really bad part about this would be a fecal impaction. So that's when there's a hardened mass of feces that creates a blockage. And this could lead to a small bowel obstruction, which can be something very serious that can even lead to death. So this is why it's very important to keep track of when your patient has had a bowel movement and how frequently they've had one, and you need to advocate for them to get something to assist them in doing that. So this is very, very common with immobility. And then the genitourinary system, so urinary retention, because you're sitting in a lying position, gravity's not helping you out. It can cause incomplete emptying of the bladder. Obviously, if there's not a Foley catheter in place, if there is, then it should empty most of it out, but still, because of the position, sometimes the Foley will even have difficulty draining all of that. And then renal calculi, so that's like kidney stones. So incomplete drainage of the kidneys and urinary retention can cause kidney stones to form. And then both of these, especially the urinary retention, puts them at high risk for getting a UTI or urinary tract infection. Okay, so effects of decreased mobility on the integumentary system. This one is probably the most obvious one. I'm sure you've heard of bed sores, pressure ulcers. So this is a picture of one on the sacrum, over the sacrum. This is a very common place because of that bony prominence, and it's got the pressure up against the bed. So there's different levels of this skin injury or skin breakdown. So stage 1 is intact skin. It's non-blanchable. So that means when you put your finger on it, it doesn't go white and then come back red, to show that it would have like good circulation. And then there's redness, but there's no maroon or purplish discoloration. Stage 2 is a partial thickness skin loss, a pink-red wound bed that is moist and viable. So that means that it's still healthy at this time. And then it may include a ruptured or intact serum-filled blister. Full thickness loss, that is when the fat or the adipose tissue and the granulation tissue can be seen in the ulcer. A lot of times it'll have rolled wound edges, and there'll be slough or eschar, which is dead tissue, may be present as well. There also can be tunneling and undermining. Fascia, muscles, ligaments, tendons, cartilage, and bone are not visible, though, in stage 3. So stage 4 is full thickness loss, and at this point, you can see bone, muscle, ligaments, things like that. And then you'll still have the slough and the eschar. Stage 5 is considered unstageable. Slough and eschar conceal and cover the extent of the tissue loss, so we can't fully assess the damage. So it can't be determined if the injury is a stage 3 or 4. And then stage 6 is a deep tissue pressure injury. It's a localized area with a deep red, maroon, or purple discoloration, which is non-blanchable and may include an intact blood-filled blister on an exposed dark wound bed. So this one's not going to be open, but it looks like a really deep bruise, that blood-filled blister, and so that's showing that there's a deep pressure injury, deep tissue pressure injury. So the reason that this happens is because we have bony prominences. So you can see this man, it's the back of his head. Think about elbows, knees, heels is a big one. We talked about the sacrum. That anything that has prolonged pressure, and so it reduces circulation to that area. So then what's going to happen is the tissue is going to start to die. So this is something that we have to watch for really closely and make sure that we're turning our patients and that we are using pillows and other devices to prevent these ulcers from happening. So nursing interventions for this would be to turn Q2 hours and more frequently if needed. In clinical, this week we had one who was Q1 hour turn, and he was a quadriplegic, already had a stage 4 pressure ulcer. You could see his bone. So it was important to turn him more often. And then to do range of motion, have physical therapy come help to promote mobility. And it's important to keep the patient dry and clean, because when the patient is wet, their skin is moist, then they're at higher risk for developing skin integrity issues. And then you also want to keep them clean. So if they're sitting in urine or feces, their skin's going to break down a lot quicker. So TED-HOs and SCDs, this is what I said earlier, it's not STDs, it's SCDs. It's sequential compression devices. You may have seen them or may have even had them if you've had surgery, but they're kind of like little leg massagers. They fill up with air and kind of help keep things moving in the lower legs. And then you can also, sometimes they'll have like Lovenox or something like that, just as a pharmacological anticoagulant. And then you want to encourage coughing and deep breathing and the use of an incentive spirometer. A lot of times patients after surgery, they will have that prescribed by the doctor, and this just helps them to take deep breaths. Keeping the head of the bed elevated. This is going to help promote breathing and encourage fluid intake so they don't get dehydrated, and those the mucus and blood don't become thick from being dehydrated. So then we want to assess mobility. So when we're taking care of our patients, we need to know how mobile they are, and this is really going to kind of determine our interventions. So, activity intolerance, a lot of the patients will have this if they've been in the bed for a while, just because their heart could be deconditioned. They could be, their lungs are not working very well. They may have a little pneumonia developing. Their muscles are atrophied. They're stiff. So all these things working together are going to create activity intolerance. So they don't have the energy to undergo or complete necessary activity. So activities of daily living, we talked about this. Basic essential skills, usually related to personal care that a person performs every day. So you want to assess if they can complete those for themselves. And you kind of want to know if they were able to do all these things before they came in. And now they can't. So we've got an issue. But we always want to get them to their highest level of independence. Kyphosis, you've probably seen little old ladies with this. When they're kind of bent over, it looks like a hump in their back. And this is just the outward curvature of the thoracic area of the spine. It's most commonly occurs in older adult females due to weakening and breakage of the vertebra. So it's something just to make note of, and know that their center of gravity would be off. So they would be at higher risk for falling. And then your mobility assessment, there's several different assessments. Usually it just kind of depends on the facility, and they'll usually have to fill it out every shift or a few times a shift. So it's just an objective assessment to determine the amount of assistance required for ambulation, walking, and transfers based upon the client's abilities to move. This is good information to get when you're getting a report from the previous shift nurse to kind of see what their assessment of them was, so that you know kind of what they can do. So dangling, this is something that's going to help with orthostatic hypotension. So helping the patient sit up to the side of the bed, have their feet dangle over the side, and let them sit there for a little bit. Just to kind of get their bearings, and this will put them at a less risk at falling from orthostatic hypotension. You also want to make sure that they've got non-skid socks or shoes on before you walk. This is very important to prevent them from slipping. The gait belt, it's the wide, strong belt that goes across around the patient's waist, and the caregiver can use this. You'll see physical therapy use it a lot to help lift and kind of stabilize the patient. And then the cane, so it increases stability and improves gait mechanics. Walker assists with ambulations for clients with balance or weakness difficulties. So this is the greatest amount of support you can get as far as a walking aid. And then crutches, they're usually just used for younger clients because they have the muscle strength to be able to use them. So instructions on cane use. So you want to instruct the client to hold the cane on their stronger side. So if my affected side is my left leg, I'm going to hold it on my right side. The elbow needs to be at about a 15 to 30 degree angle, so you have the cane close to your body. Position yourself on the affected side. This is for you to help a client who's walking with a cane, and slightly behind the client. You want them to advance the cane 6 to 10 inches, support their weight on their stronger leg and cane, and then move the weaker leg forward parallel to the cane. So they're going to move their cane and then their weaker leg. And then with the weight on their weaker leg and the cane, then they're going to move their stronger leg forward past the cane to complete the step. So use of walker, after the client stands, instruct the client to hold the hand grips on the walker firmly. Now, we don't want them to bend over like we saw in that one picture and put their center of gravity way off to where they are at higher risk for falling with a walker. They still need to be standing upright Their elbows need to be at about a 15 to 30 degree angle as well so that it's close to their body. And then you're going to position yourself slightly behind the client on one side. Instruct the client to move the walker forward 6 to 8 inches, setting it down all 4 feet on the ground, all 4 legs of the walker. And then while supporting their weight on the walker, tell the client to move 1 foot forward, following with the other foot. And then they will do the same thing again. They'll move the walker forward, 1 foot, and then the other foot. So crutches. So we want to make sure that the client can use the crutches first, that they're strong enough. We need to make sure that they have the crutches at appropriate height. So the client is going to stand erect, face forward, hold the crutches 6 inches in front of them and 6 inches to the side of each foot. So there's different gaits that you can do with when you're using crutches. So the 4-point gait is to tell the client to move the right crutch forward 6 inches, followed by the left foot, and then moving to the level of the right crutch. Then the client will move the left crutch 6 inches forward, followed by the right foot, moving to the level of the right crutch. So then this is your 4-point gait with crutches, and you guys will practice this in lab. And then the 3-point gait is to instruct the client to move the affected leg and both crutches forward 6 inches. Then move the stronger leg forward to the level of the crutches. So that's a 3-point gait. And then 2-point is instruct the client to move the left crutch and the right foot forward 6 inches, followed by moving the right crutch and the left foot forward. So now we're going to talk about patient positions. We'll talk about Fowler's position. This is the most common one. Really, semi-Fowler's is going to be the most common bed position that you're going to see. Usually they have orders to have the head of bed at least 30 degrees. So you have your low Fowler's, which is 15 to 45. Semi-Fowler's is 45 to 60 degrees, and high Fowler's is 60 to 90 degrees. So this is going to promote decreased risk for pneumonia and just help promote overall health. This is the orthoptic position. So this is going to kind of be for someone who maybe is not breathing well and they're wanting to sit up. So you could have the bedside table in front of them and have a couple pillows on top of it. Okay, and then this is just a supine position. They're supported with pillows, so the one under the legs is to help offload the heels, is what you'll hear, but it's just to keep the heels off of the bed, to keep them from creating that pressure that could lead to an injury. And then this is prone, so this is on their stomach, and then they've got pillows supporting them as well. This is Sims. And then range of motion. So this is, you can have passive or active range of motion. This is just moving the joint within its range of flexion and extension. So passive range of motion is when someone else is doing the movement. So if you have someone who's immobile, you still need to have physical therapy, and you as the nurse can be doing passive range of motion so that they don't get stiff and get a contracture, help prevent atrophy. And then active range of motion is the voluntary movement of a joint. So if a patient can do this for themselves, we can do this, move our body joints, within the amount of the normal range of motion. So here's a list of the types of movements. And here's just a little diagram that kind of shows you some of those motions. But flexion, so flex your knee, reduces the angle between the bones. Extension is to straighten the limb. Abduction is to move away from the baseline. So think of abducted, away. And then adduction is bringing closer to the baseline. So you're adding something. Pronation is turning to face backwards. Supination is turning to face forwards. Circumduction is a circular motion. And rotation is side to side. Inversion is to turn inward. Eversion is to turn outward. Dorsiflexion is to draw toes up towards the body. Sorry, I cut off. And the plantar flexion is to point toes downward away from the body.